so don't stress if you're there. Feel free to continue to get your coffee. For those who didn't explore the back end of the room, there are a bunch of danishes in the far end, and for dietary requirements, there's another table on this side. So have a bit of a walk around and explore if you're feeling hungry, and as always, feel free to get up and walk around during our presentations. As mentioned yesterday, we have 3 to get through today. So the rough plan is that we'll have about a 5-minute break between each presentation. We've done a bit of a room shuffle around. There's speakers in new spots, TVs in new places. So if you are struggling to hear or see, please just let us know so we can continue to change the room to make it work for everyone that's here. Otherwise, as you enjoy, I guess, the skyline lighting up in the background, let's welcome Mark Corden back to stage to talk about communication. Thanks, Mark.
Thanks, guys. Thanks for having me back, and thanks for waking up the hill so early in the morning. This will be a different talk to yesterday's talk, a bit calmer and a little bit slower. I think it was probably a bit brave to think I could get through 80% of basically my entire chosen career and passion in 50 minutes, and that's probably a good thing. It means I've done it all my life. Today's talk will be more of the text style talk, only a few real points that I want to get across. I accidentally rewrote the entire thing last night when I was just giving a quick one-set proofread. I found one word in it that really triggered me in a way, so I rewrote the entire thing. So it was parents and families, but now it's also about staff and the principles of earnest and respectful communication. It's not just from us to families, it's us to each other, and it's basically us to our society. Basically, trying to work in on David's lovely points that we are just here to administer cures and drugs. We're here to heal families and ourselves as we go. So, what are the basic messages? I was going to call this slide principles. It's not the principles, it's just what I really feel about how to communicate really well. One of the things I find my training doctors, residents, registrars, they have this desire in a busy environment and need to be efficient. Efficient means to be quick, and efficient means to use very few words. Basically, they're almost coming along from here, registrar. I love my community colleagues. But they speak very fast. They often cut families off. They use short words. Pressure is to be efficient. My point is, it doesn't save you time to speak too quickly. It doesn't save you time to cut families off. It takes very little time to really spend 1 extra minute at the start, establishing a rapport, listening really well if you can. The time you spend at the start, you save at the end by having a much better rapport. So the need to be efficient is not cut off. You actually make more time. You save more time with families. You can just listen a bit more at the start. A boss of mine once said, oh, in the ED it's great, we've got a really flat power differential, power hierarchy. And I thought that was a lovely idea, you know, the seniors and the juniors all being on the same level. But I think it was a bit too aspirational. There is always going to be a power differential between you and the patients you see and the families you see. And that's supposed to be there. I'm not saying it's a great thing, and when abused, it's a horrible thing, but it is there. Patients will see you because you have knowledge and abilities that they don't. I will see a specialist because I don't know anything about my own physiology as an adult. I know paediatric physiology very well. Parents will see me because I know that. So there is always going to be a power differential. To ignore it, pretend it doesn't exist, or to try and work it away is actually going to do you a disservice. You can, if you use it properly and well, it's not a bad thing. If you use it with full benevolence and intention, genuineness, then it's actually going to be quite fine. So we can't work it away. We don't live in a hierarchical, less society. We certainly don't work in that society. So we may as well use what we have. As an old bloke with grey hairs and the COVID kilos that still haven't gone away, I think one of my main jobs when I talk to my residents and my registrars and the junior nursing staff is that parents are tired, they're scared. They've been up all night with their sick kid, so they're not thinking completely well. They haven't had a good night's sleep for many nights, arguably years, so they're tired and scared. And the second you forget that, you've probably lost half of the game. So just to remember that parents are tired and scared at all times. And pay close attention to your word choices. And again, this is not an arrogance thing. When we're seeing sick kids or scared families, we are scared because we want to do our best job. So our fear, again, is a beautiful thing that we can use. But when we're scared, we often fall back on our safe space. And our safe space is going to be the years we've spent in university and school and working. So our space is going to be jargonistic. It's going to be what we've learned the whole time. I can tell you, enormous examples. I had a registrar who I trust implicitly, extraordinarily senior doctor. I would let him take care of any of my kids any day of the week. Just chatting the other day, parents said, "Oh, what's this antibiotic for?" And he said, "Oh, it's just prophylactic, don't worry about it." And they walked out the door, and I hadn't put my bag down and started my shift. I was like, "Oh, are they a medical family or a pharmacist family?" He goes, No. Oh. So, what are they going to take away from the word prophylactic? And him, it was just trying to be efficient, trying to be quick. And again, he had 4 other patients on the go. He was probably a bit stressed. So he just leaned on what was natural. If we lean on what's natural and we forget the parents and families in front of us, again, we've lost the game. And this is basically the whole talk. So I can put the microphone down now to finish our scrolls. But I've got a little bit more to say, as you know, because I always talk. All right, so today I want to talk actually about the principles of good education, not just my feelings about it. Give a couple of case examples, go through some resus guidelines. There are resus guidelines on how to communicate in a resuscitated, extremely stressful scenario. And there are a couple of points that I think we should try and pay attention to. And then, can we actually have an evidence-based approach to communication? Yes, this talk is hopefully as much art as it is science, but can we still use a bit of science for it? So, a lot of this might seem really obvious. Yes, we're all sort of modern, fluffy bunny doctors and nurses and ambos, so yes, we all want to be good communicators, but we can always still stuff it up. So, it is good to remember that really good, effective communication does involve, yes, respect, active listening, and clear language. It just involves genuineness. Like, we're going to make mistakes. So if you make a mistake in caring for someone, how do you get over that and not let it destroy you? My own personal opinion is, if you start every shift, every interaction with the genuine desire to just do something good for the people in front of you, even if you make a mistake, you've really just tried your best. And if you're communicating and you try your best, then these principles just fall into line. Acknowledging the patient's role. This is a lot of what David was talking about yesterday. The patients and the families, and the triad of communication. Because with paediatrics, it's not you and the patient. It's you and the child and the caregivers. It's not a dyad, it's a triad of communication. So, engaging the families, all of the children and the patients at all stages. You might say, "Hi, my name is," and it's actually surprising to remember how few of us actually say, "Hi, my name is." We often just forget to introduce ourselves. We've got the triage complaint, we've got the call-out sheet, we're trying to find the address if we're rocking up to their house, and we forget to go, "Hi, I'm Mark." And if you really want to expand, "Hi, I'm Mark, I'm not busy today." Just a quick introduction of who you are, and then what's going to happen. So a family, you might have gone into a cubicle if you're working in the ED, see a quick family, "Yep, we're going to do this, we're going to sort out a test, and hopefully we'll get you home in an antibiotic." But how long is that roughly going to take? A little bit of expectations management is really going to go a long way. Set the expectation. The cynical way of doing that is that old adage of, under promise and over deliver. And I think that's actually a bit of a demeaning way of doing it, because it doesn't give enough credit to the people in front of you. So if you know, for example, you can do a blood test and a full blood count takes about 70 to 90 minutes, depending on your institution, to come back, say, "Look, on average, it's about an hour and a half." And then we'll have that back and we can finish our conversation. If you just set the expectation so you can meet the expectation, that shows respect, and it just shows a bit of practicality that the families are really wanting of us. Okay. Is this just lip service? Is a good communication actually necessary? Well, obviously I feel that it is. An example many years ago was a consultant when I was a very, very junior resident was telling me, look, you know, I can spend all this time with this family, and if they don't want to take it, that's up to them. And my thought was, you've just wasted your time. And you've wasted their time. You've spent 30 minutes with a patient, and it doesn't matter to you if they take your advice or not. You've wasted 30 minutes of your life, and theirs. And they have to go waste someone else's life to seek the healthcare that they really need. So, good communication and rapport actually positively, definitively improves health outcomes for you and for the patient. So this isn't just lip service, this is what's having a really meaningful impact. How can it be done poorly? Well, this case is actually MC is me and AC is my younger. And so my youngest child, Antoinette, just went in for a pretty standard adeno tonsillectomy, tonsils adenoids out, thanks very much, should be a quick day case. Went in, and then that, on the other side, it's really different. Here we are, my wife and I, giving our youngest daughter over to somebody else to anaesthetise and somebody else to perform an operation on. Standard operation, bread and butter for an ENT, but still the anxiety in us was palpable. And we are the nightmare parents for healthcare providers like yourselves. We're a paediatrician and a lawyer, and a medical negligence lawyer. Not how we met. But, so we are the worst parents ever. We don't say it, but everyone always seems to know. And so we are the worst parents. So the anxiety amongst the staff was palpable. And so of course what happens, there's a medical problem. But only by connecting the dots. On extubation, it was an oropharyngeal procedure, a laryngospasm. So she was re-intubated. But we think overdosed because in the standard post-operative environment, she had to give a naloxone just to wake up and stop having an oxygen requirement. But the entire time, they were sitting next to our daughter who's completely catatonic, on oxygen, and we were told she'll be awake in 15 minutes, and an hour and a half later, nothing's happened. All we wanted was to know what was going on. You know, what's happened to our kid? And all we got told was, oh, everything's fine, she's in the right place. That's all we were told. General platitudes that have zero meaning. And that's the worst thing. If they had said, look, on extubation, she had some spasm, we had to re-intubate, so now she's really sleepy because of all the extra drugs we had to give her, but they'll wear off, well, that makes sense. And that's what we wanted. But all we got was general platitudes. You're in the right place. It's something that we might have all said, or at least have all heard somebody else say. And it was meaningless and unhelpful. So what's important is to be not humble, but to have humility. And just understand what patients and parents really want from you. And then it's easy to provide. You can be transparent and genuine. Even if a mistake happens, okay, laryngospasm happens, doesn't mean it's a mistake. But I need to know what happened as a father, not just a paediatrician, but as a father. I need to know what's happened to my kid when I gave my kid over to you. All right. So, where in the resus, like let's go with the real hard end of the stick. There's some ILCOR guidelines, international guidelines on resus. A colleague of mine was the trauma surgical fellow for one of the major surgical hospitals in Melbourne, and he was telling me this story about how they ran a sim. They don't do paediatrics in this hospital, fine, but they ran a sim on a teenager who had been hit by a tram outside the front door. Very Melbourne scenario. However, it was a great scenario. And he's telling me, well, of course, we've got the sim actor to be outside whilst we dealt with the sim in the room. And as a paediatrician, I thought, oh, that's a shit. But maybe that's just my perspective. It turns out it's not. It is basically just my perspective. From the family's outcomes, parents who were involved in the resuscitation, and the fear is they're going to be throwing themselves on their child and wailing and distracting everybody. They don't. They're scared and they're in shell shock. But if they're in the corner, watching us do everything we can, and if we even have the resources to assign a staff member to talk to them and explain what's going on, that's if that staff member is free and exists, of course. But if it's there, brilliant. But if they're there, they do better. Very few parents ever choose not to be in there. And if they choose not to be in there, that's a valid choice. But few do choose not to be present. So So to deny them the option, I think, is not achieving a standard that we should be getting. But I think paediatricians would be happy having a parent there, and most others who aren't dealing with families on the day-to-day would not be happy. The stress of it. I remember the stress. When I was a junior doctor doing a lumbar puncture on a baby, I always hoped the parents would leave so I could do it. Now I'm on, I don't care. Stay, go, doesn't bother me. But I remember the stress. So if you were to choose to ask a parent to leave, I would understand. But I would implore you to try and get them to stay and be involved, because this will be better outcomes for the patients and the families in the long term. And this is basically where the research goes. All right. And only sort of 3 or 4 weeks ago, the Victor charts, these are the observational charts in Victoria. I think New South Wales call them between the flags, we call them Victors. Basically those beautiful colour-coded charts, too high, too low. Safe Care Victoria, which is like the governing body of safety for Victorians, are putting in a question. We know that parents are bloody good at this. They know their kid. So if they are worried, the kid has actually got 4 times higher likelihood of going to ICU, and if they are worried, the kid is 5 times more likely to die. So we have to listen. And so the listening question is actually going to be piloted into our OBS chart. Heart rate, breathing rate, pain score, temperature. Are you worried your kid's getting sicker? A standard OB now. And I'm very confident for this pilot. Okay. So you're asking them, is your kid getting sicker? How do you listen? You need to let the parents know you've got your full attention. And I know, again, the pager might go off, your phone's going off. That's really tricky. But I'll be with a patient and my phone is going off all the time. And I'll sort of ask them to pause, answer it, put it down, and go straight back to the conversation. It's really trying to make sure that they have your attention. And if their phone goes off, because everyone's got 1,000 phones these days, and the kids are there, and all the aunties and uncles and the parents, and everyone's calling and go, how's your kid? And they go, oh shit, sorry, my phone's gone off. It doesn't matter. Life doesn't stop. And that's my favourite saying. Life doesn't stop just because you're here, and they understand that you understand that shit is real and shit is hard. So listening well is trying to really understand. If during a full history you can reflect something back, it sounds like you were really worried when that temperature was high. Shows that you've listened, absorbed, and can reflect back. And you're asking them. It sounds like you were worried. Well, what was your biggest worry about that? You're asking them their opinion. Bring it into the ED, and patients are often satisfied with our communication. It can be good, it can be bad. You can have a good day, you can have a bad day. You can not have slept, your kid could have been awake. You could have crashed your car that morning or something. So again, we can't always be perfect. We will always be human. We can always just try and lean on our humanity if we can't lean on our perfection. Factors that make communication really difficult is this pressure and this time. It's almost artificial need to be as efficient as possible. Efficiency matters, but communication facilitates. Communication does not get in the way of that, in my opinion. Language and cultural barriers are, we live in a beautiful multicultural society. My hospital, the Northern Hospital, is actually one of the most multicultural centres. I can't get through a day without requiring a few different languages on the translator services. It is absolutely excellent. I love working in such a broad society. And I think I love it because not only is it fun, it's the challenge, because language and cultural barriers are definitively shown to increase adverse medical outcomes for patients and families. So trying to work around that and get over that to deliver the care that you would want to get is grossly important. So if you can, always get an interpreter, and an official hospital interpreter, not the 16-year-old cousin who speaks great English. The last fundamental is, it's us. Doctors and nurses often overestimate the health literacy of our adult patients by about a third. And the health literacy, and I'm not saying literacy, but just health literacy, because health is hard, especially in the way we've packaged it, with GP, primary care, secondary care, tertiary care, Medicare, bulk billing, private insurance, this combined state and federal funding model. It's a fucking nightmare out there. And we live in it, so it's natural to us. but it's not natural to our families. I'll see a kid, and I can tell if a kid, there's a show called Operation Ouch on ABC and BBC. It's a fabulous little show. It's two twin ED doctors in England, and they have this little show, and they'll take a little story of a kid who's kind of hospital broken up something, and they go through. I can tell if a kid has watched that show because they're in the ED and they're all pretty familiar. This looks really good. And a kid who hasn't seen that show is scared shitless of the curtains, the room, the lights, the scrubs, everything. The difference is familiarity. We are very familiar with this environment, so it's natural to us. And it's easy to forget that it is not natural to them. All right. One thing I can touch on just for take home is a movement again from England called Civility Saves Lives. There's a very lovely TED talk by a chap called Dr. Chris Turner. It's a 50-minute TED talk, it's beautiful. And he talks about the evidence base of just being nice to each other, or civil, i.e. if someone's a bit of a prick in a room, tension rises. When you're tense, you aren't thinking at your best, and mistakes rise, and outcomes dip. And again, this is done through SIM. They did SIMs where there was just even an aggressive phone conversation. No one was actually directly inhibitively talked to in a bad way, but they could just even hear the negativity on one of the SIM team members, and performance as a group dropped, which means outcomes dropped. So that's just why I started putting in last night when I rewrote this until 11, that civility is not just important between us and families and parents and patients, but to each other as well. So this is the TED Talk, and it's absolutely fantastic. He leans on these tests, so again, evidence-based for a bit of just not being a prick. The thing that triggered me last night was this article here, nursing-based article based in Australian studies, Australian hospitals, pardon me, and the line here is training staff about speaking up for safety is required. Now, this is where I'm going to go full old man, and I think training people on speaking up for safety is shit. Not because it's not worthwhile, but we've got completely ass backwards on it. Why? We've all done probably introduction seminars. We've seen little videos on how to speak up for safety. You might have even seen like the College of Emergency Nurses Australia have this really great graded assertiveness protocol. Ideally, this should be unnecessary. We shouldn't be asking our juniors to be speaking up to us. That's the problem with speaking up for safety, that it should have to happen at all. We all should be modelling the behaviour, not demanding the behaviour of those below us. There's an article, a fabulous article written by Dr. Ben Simon. He's a PEM, like me, but better, and lives and works in Queensland. He wrote this article, published on Life in the Fast Lane. It's a few years old now, but I read it about once a year. And I actually shared it to my consultant group a little while ago. We were having conversations about safety. And I shared this thinking, we've got this completely wrong. We've got this wrong. And I want to read a little excerpt from this. The story is about how he came out to his parents and the difference with how he was accepted versus his partner when he came out to his parents in a very different cultural context. And so this is just one excerpt from Ben Simon's article. He says, I mention these stories because at every corporate orientation I go to, we get a little speech on speaking up for safety. It is well-intentioned and feels nice. Everybody is moved at watching some video about a plane almost crashing, and they smile and nod and say they will definitely speak up. But in the back of my head, I hear my father's talk, and I think, but we won't. Not most of us. Why do we think we're going to solve medical error by instructing our most junior staff to stand up to us? They might want to, and some individuals will stand up to the system. But at the end of the day, most of us won't. And it might sound defeatist to argue that expecting people to speak up is an unfair waste of time, but I think it's true. History is littered with examples. Look at the Stanford prison experiment. Look at Manus Island Detention Centre. And you think they're going to speak up just because you got the dose of propofol wrong. Such hubris. And I think that's right. So, how do we do? how do we fix this? It's very simple. Every time a junior or a nurse or an M or anyone asks me a question, I'll give my answer. And then I'll say, and what do you think? All we have to do, and this can be a resident to a medical student, a registrar to a resident, it doesn't have to be just from the top down, it can be at every tier of this hierarchical institution. You can give your answer and say, and what do you think? If we model listening and we ask questions, then we'll have a much better team experience. Okay, so to the patients, can we have an evidence-based way to communicate? The short answer is, yeah, pretty much. I can reference this study here. I love this one because they didn't experiment on patients, they experimented on doctors, which is a great fun time. It was called nudging. This was an American study, inpatient, so less acute, but the principles are very there. One group of patients had a chair plonked at the bedside, and one had the standard care of a chair hidden in the bloody cupboard. The patients were in the room, were set up just with the chair there, the doctors sat down far more often, and the families had a better experience. American healthcare, one of their main metrics that we don't have is patient satisfaction scores and surveys, but as a corollary to sort of patient care and outcome, again, if they like you and they like what you say, they're more likely to engage in what you feel is best for them because it's a communal decision. So the second you This is the best heckle I've ever had. This is great. I once got heckled by Siri, but that was much more pleasant. So the second you sit down, you feel more human, and your message is more human. Second one, this is an ED one, where they just put awful little stools, but you can pick them off and collapse them. And any time a doctor sat down, for any period of time, it wasn't the whole time, if you sat down even for a few moments, patients had a better experience. You are more relatable. You are not just standing over and going, what's wrong with you today, mate? You know, justify your reason for coming in here. They have to justify squat. They're scared. That's why they're here. The second they sat down, you seem more polite. They feel more cared for and listened to. So the second you get down, that's it, you're winning. And with kids, the older I get, the harder it is. But kids are smaller, obviously. So you have to get down further. You have to get down on your knees. You have to kneel down. Because if you want to examine a kid like this, they are fucking terrified. You are huge. If you get down and wait and then examine them, again, you've won the game. And parents really appreciate that effort. They understand, they can see that you get it. And that's what matters. That's when you've won. Words. Again, these antibiotics are prophylactic, or just take them PRN. The words we use have to matter, and they just have to be simple and meaningful. Patients will be confused at all times if we just speak the way we speak to ourselves and to each other. They're not doctors, they're not supposed to be doctors. One of my favourite sayings is, I might be an expert in this, but you are the expert in your child. So through this, we need to get onto the same page so we can all work together. And they are experts in themselves, they are experts in their kid, and you are the expert in what you're doing. So you start with that premise, you set that expectation, and you can meet that expectation. That's my favourite bit there. Okay, so word choice does not just cause confusion, word choice can hurt. Okay, so in times of stress, patients are heightened. I mean, a heightened person is a great candidate on a stage to be hypnotised. Hypnosis can be sort of almost self-induced. The more you use painful words, the more pain a patient will experience. So we have placebos and nocebos. Thankfully, nocebo is not a fancy play on words. It is actually based in Latin. Otherwise, I was going to really hate that term. Even some things, like if you give someone a drug and then give them a vomiting bag, they are far more likely to be nauseous and possibly vomit. So this is not just, again, you might say Marcus Airy-Fairy for first thing in the morning, I just want to watch the sunrise, and I wouldn't blame you, but this is completely true in physiology and in evidence. Warning someone that something is going to hurt will make it hurt more. Does it mean you lie to them? No. You just say, some people might find this an unpleasant experience, or it might cause some other sensations, but you can avoid the words of pain. And minimising words, which we all use. How many times have you popped a cane on someone? This will just hurt a bit. Just a tiny sting. If it's a little kid, I generally don't have the time because they're too busy screaming against the restraints to find me. And if it's a teenage patient, I'm just going to say, mate, here comes that prick with a needle. Play on words. They usually get it. But the minimising words don't help because the words they hear sting, hurt. That's all they really hear because that's all that really matters. Alrighty. So, what not to say? I sound like a muppet when you say this, but trust me, I'm the doctor. What I'm trying to say is, please trust me. I know what I'm doing. I've tried this before. I work on this. I want you to trust me. What they hear is, I'm smarter than you. Your opinion doesn't matter. Another thing of what not to say, don't worry about that. Because they're going to worry about that. Also, your thoughts and your feelings are invalid. If you're worried about that, what an idiot. Alright. Any other examples of what not to say? What's a stupid thing that you've heard maybe come out of your own mouth or a colleague's mouth? Too much paperwork? That's horrible. Any other good options of things you've heard? Oh mate, just don't do that. I can give an example. A resident asked me, he says, how do I convince his parents not to do an x-ray because their kid's got constipation? Fair, good call. Doctor's right, but the premise, how do I convince the parent? If you come out, in paediatrics, if you come out all guns reassuring, you've lost the game. If you try to reassure someone straight away, you're just riding over. So we went in there and we had that talk, sort of half gave last night, of abdo pain and how 50% of the time we never know the cause, and we can do all these tests and investigations and it doesn't matter. And oh yeah, actually the last time she did a poo, it was really sore, and I can actually feel a bit of poo when I examine this tummy of theirs. So, you know, thankfully, because she can move, we noticed beautifully jump up and down, there's no appendicitis, because the diet, there's no vomiting, it's all this, it probably is constipation. Did you want that x-ray? And after we explained it all, we shared our mental model. It's like, hell no, I don't want the x-ray. We didn't have to convince her of a damn thing. We shared our thinking. We were completely on the same level. Didn't want it. It's not about reassuring. It's about sharing your mental model. And then if you're all on the same page, you don't have to reassure a damn thing because we're all sharing the same thing. All right. So, sit down when possible and kneel down for the kid. Don't ever just come in all guns reassuring because you've missed the point. Listen first, it's not a time waster, and you'll get to the end. I will just give a quick example. This is a talk that I give many, many times a day. I've practiced it over many, many years, the fever talk, because parents are terrified about fever. What are they terrified about? It's going to cook the brain. Cook the brain is a common belief across all generations, all cultures. I see it all the time. So how do you do it? Like, what's the worst way to do it? Don't worry about the fever. Don't worry about the number. I hear that all the time. That's the worst way of doing it. My way of approaching the parents who are genuinely, and fair enough, anxious about their child with a temperature of 40.1 degrees, and all their aunties and uncles that are telling them it's going to be terrible, is this. I'm like, okay, well, when you and I were kids, so already, you know, well, maybe more me than you, 45 more years ago, you know, our parents and our mothers and fathers and aunties and uncles, they were all really worried about the fever. They were worried it might cook the brain. Parents like, yeah. And I've already started with you and I. It's not you versus me. I've just kind of shuffled to the side, and we're on the same team now. Bit of this. Our parents, our mothers and fathers, aunties and uncles, they were worried about the fever. You displaced the responsibility for the belief onto someone else. This time the shoulders of the older generation. Thankfully, since we were kids, so 45 more years of research in paediatrics, we now know that's not true. I mean, technically, fever is natural. What a great buzzword. Fever is natural. Our bodies make it. And our bodies make it for good reason, two good reasons. The first reason is, in the setting of fever, our immune system works hard. It's like a feedback loop. And the other reason is the things that make us sick, the viruses, bacteria, fungi, parasites, whatever, they're like us the way we are. 36, 37. So what's going hot makes it harder for the bacteria and the viruses to make it work. So technically it's a good thing. So what do? Well, if the kid is hot, and it doesn't really matter how hot, 38, 39, 40, hot is hot. Hot but happy, playing with blocks, eating, drinking, no worries, let the fever do its job. Again, you're implying the function. But hot and unhappy, well, that's pandolurifin time. So again, if you just go, don't worry about that, you're invalidating generations of belief. But if you can displace responsibility, you're not attacking the family when you explain it to them, and everyone's coming back to the same page. So you're sharing your mental model. So that's it, not as an intense talk as last night, but I hope one that has more immediate take-home points. So the main messages are, communication doesn't cost time, it saves it. Start early and you're winning the game. And the patients are going to have a better long-term outcome. We should acknowledge the power differential that exists. We have knowledge that they don't, that's why they're in front of us. But it doesn't have to be a bad thing if we use it with genuine humility and genuine intent. Definitely pay close attention to your word choices. Just use normal words that everyone would use. And get down line. Now, I didn't write this one, but I thought I could finish on this because I saw this and I thought it was absolutely excellent. How to manage expectations. Now, because nothing new under the sun, there's a little, and you like a framework, there's a framework of expectations management, acknowledge, introduce, set expectations. This will take this long and then I will come back. I might be a bit later if it's busy. They get that. But to set the expectations so you can meet the expectation and then everyone's a winner. And thank them for their time. Like they've come out of their day to help you have your job. So may as well thank them as well as them thanking you. All right. Any questions on that one before we move on to the next speaker? No? All right, well thank you very much for your time again.
Thanks, Mark, and thank you to everyone for putting up with the jackhammer and hammer drill in the background. The good news is they're building us a new conference room for next year, so get excited. It's going to have high ceilings and it's going to be looking great. So a little bit of pain today, hopefully it won't go on for the whole time. We're going to do a quick computer swap. Feel free to stretch the legs, grab a coffee, and we'll get started in a couple of minutes.
Thank you. There's a microphone. Oh, that was loud.
Oh, sorry. All right, we're on. All right. Ooh, this is very, very loud. Sorry, I'm Australian. Welcome. So, first things first, let's introduce ourselves. So, my name's Oliver. A little bit about me. I'm a clinical nurse currently at the Gold Coast Hospital. Been in ED for the majority of my time. Did spend a bit of time in New Zealand as well. Presenting with James.
Hi guys, I'm James. I'm one of the registrars at Gold Coast. I have the pleasure of working with Oliver regularly.
So look, these guys tell me that we've got a pretty even split between doctors, nurses and paramedics. But I did want to know a little bit more about everyone and just where we're from. So just by show of hands, who's from New Zealand? We've got like 3, 4, hey, 5. Awesome. Australia? Yeah, okay. Majority. Anyone from New South Wales? Yeah, a few of you. Got something in my notes here. Don't mention the state of origin. Oh, yeah, sorry. Awesome. And have we got some skiers? Yeah, a few snowboarders. Fantastic. Who's here just for the apres? Yeah, awesome. All right, fantastic. All right, we're going to get into things today. We don't have a huge amount of time. The topic today, paediatric drowning, roadside to resus, or probably renamed Prehospital to PICU. Apparently there's this small podcast called The Resus Room. We didn't want to take their name. So, pretty big topic in the sense that I think this is one of those presentations that you might not see overly commonly coming through, but it's one of those ones that carries a lot of weight. And I think when you're managing it, it can be really, really stressful. And so the aim of today is to just hopefully give you a few pearls of wisdom, a few takeaways that you can take to the next job whenever you're tasked with a job such as this. Let's see if this works. It does, awesome. All right, so a few things we're going to be going through today. So first thing is a bit of terminology and trends, how often we might see paediatric drowning, and some of the words we want to be using around it. Some of the ones we don't. We're going to have a quick look at the pathophysiology. We're then going to meet a lovely girl called Grace, who is a bit of the inspiration for this presentation, and we'll re-meet her as well at the end of the presentation. We'll talk about management, and we'll hand over to James for this. He's going to be talking a bit through some of that pre-hospital management and some of those considerations you want to have, as well as when you get to ED, and some of the big decisions that we might have to make, and this is kind of surrounding prognosis, for example. Okay. All right, so terminology and trends. So what is drowning? So World Health Organization, they give a definition. It's the process of experiencing respiratory impairment from a submersion or immersion in a liquid, okay, most commonly water. So ultimately, two things. You're going to have respiratory impairment, okay, and it's going to be coming from either a submersion or immersion, okay. Now, what's submersion? Submersion is completely underneath the water. So complete airways underneath the water. And this is what you're most commonly going to encounter when you go to a drowning. Immersion is a bit of a difficult one, and I think we came across multiple different definitions, a lot of different examples for what immersion was. And we're going to get onto this next with regard to sort of terminology that's perhaps starting to get a little bit outdated for the main reason of it just doesn't really matter. Immersion was kind of like you're in the water, or maybe there was water splashed across your face. Life in the fast lane, give the example of waterboarding. Bit of an interesting one there. Hopefully not something you come across too commonly. But it's also potentially just one of those steps that precedes submersion. So you might have a patient who goes through immersion and then progresses to submersion, okay? And that's when you're then going to encounter it. So as I said, talking about some terminology. So some of the outdated terminology that you may still come across, and this particularly comes as well from parents of the children that you may be encountering, are things like primary and secondary drowning, active and passive drowning, and particularly a pet peeve of mine is near drown. Okay? You can't nearly drown. Nearly drowning ultimately is just that you got rescued, okay, and you didn't drown. Same as nearly dying, okay, you either did or you didn't. If you didn't, you just survived, right? Okay? Why is it important to have the appropriate terminology? Well, it's really important when it comes to data integrity and then ongoing research with regard to drowning, improving some of the kind of progression and treatment and management of these kids when we're delving into the research, delving into the data. But also a lot of them just simply are factually inaccurate as well. And it doesn't matter too much. I think when I was talking to parents about this, or just mentioning to friends and family, or doing a presentation here in Queenstown, secondary drowning was a particular one that came up quite frequently. Parents will come in with their children that ultimately have just been rescued. They go, I'm so worried about secondary drowning. And I think it just doesn't change our management depending on what these are. And this is also where it gets really, really grey, is if you're training junior clinicians, junior nurses, whoever it is, they might get worried, you know, do I need to change my management based on if it was active or passive, dry or wet drowning, whatever it is? And the answer is no. And so that's why we want to stick to just two terms whenever we're documenting or talking about it, and that is drowning and that is submersion. Okay? I think immersion really is starting to kind of get phased out now as well. And then ultimately you can have one of three outcomes. It can either be fatal, or it can be non-fatal with or without morbidity. Okay? So you drowned, you survived, or you drowned, you did. Okay? Alright, so how often might we see it? Now, look, I'm not being totally aware of the audience I was presented to, perhaps people from around the world. I use World Health Organization stats, so they report about 300,000 drownings worldwide. When we look at our paediatric population, 25% of those were 0 to 5, and then another 19% were 5 to 14. So almost half of the drownings that are occurring are in that sort of children age group. It's something that I think, as I said, you may or may not ever see a drowning or rarely see a drowning presentation. But it does occur a lot more frequent than you think, particularly when we see them in the department. So for every fatality in the general population, you get about 3 non-fatal drownings that require hospitalisation or require a presentation to the emergency department. When we look at the under 4-year-old age group, that works out to be about 8. So quite a lot of presentations that perhaps don't necessarily need admission. They might not be critically unwell, but might need at least assessment and perhaps a bit of time spent in the short stay area. So what's the most common cause? In paediatrics, accidental. Counts for about 97% of the cases, okay? Either they've fallen in, okay, or it's while they're swimming or bathing, perhaps swept in, okay? Unlike our adolescent age group where the majority is intox, okay? Like all sort of presentations, you know, you want to consider a broad differential, what might have caused this, and you do want to think about things like epilepsy, okay? Did a seizure precede this event? Was there any trauma involved? I think with those presentations, it's likely to be somewhat obvious. Either a history of epilepsy, okay, a history of perhaps diabetes and there's been a hypoglycemic event, or trauma, there was boating or jet skiing involved, okay? But the majority of time it's accidental. However, like any paediatric injury or presentation, there's always that consideration of, was this a non-accidental, okay? So does the story add up? You know, perhaps just poking holes a little bit in it and getting it from a few different sources, okay? On to the idea of fresh versus salt water. Does it matter whether someone drowned in fresh or salt water? Ultimate answer is no. This is one of our myths, okay? Is there a difference in the physiology? Yes, but it doesn't change our management, okay? So what do we say? It's an argument in the academic books, okay? Maybe the mechanisms for how it occurs does vary a little bit, but does it change our management? No, it doesn't, okay? So whether you're rocking up to a pool, whether you're rocking up to the ocean, Bondi Beach perhaps, it doesn't change our management, okay? All right, we're going to start having a look at some pathophysiology.
Yeah, so let's talk pathophysiology. I think the needless to say things are, obviously, the body doesn't like water in the lungs, it's a given. And the other one is, it's a scary process. So if we start from the top, there's always a bit of a struggle. It's a scary process. Anytime anyone's drowning, you go through a few phases in there. Obviously, you start to breath hold. You'll start to flounder to try and gain momentum to get your head above the water. And we know that eventually that starts to fail. And eventually you reach what's called the breath hold break point, and you voluntarily take a gasp of water. that's where things start to get a bit spicier. So water going in goes into a few different spaces. So one, it can be ingested and goes into your stomach. Two, it can tickle your larynx and cause a laryngospasm, which essentially is a last-ditch attempt by your body not to get water into the airway. And then the third part is it can go into your lungs. So aspirated water in the lungs does a few things. One, it just takes up space for gas exchange. Two, it damages the alveoli, causes inflammation, and then probably the most important is that picture of that third picture of surfactant washout in there. Essentially, this will cause the alveoli to collapse. It causes the PICU shunt to form, and it ultimately causes hypoxemia. There are a lot of complications related to all this, and kind of the key things we've talked about are you get bronchoconstriction, you start to get hypoxia, you get an pulmonary edema type picture, and ultimately you get cerebral hypoxia and can be things like that.
Awesome. So, brief rundown on patho. We're going to jump into management, but just very quickly, this was kind of the inspiration behind doing this presentation. This is a little girl, her name is Grace, as I'm sure you figured out. So she was a girl that we treated on the Gold Coast, and we're going to delve into a bit of her story a little bit later on. But there was a lot of challenges with Grace that you would expect to see in any critically unwell drowning patient. Her prognosis was really, really poor. And I think it inspired a lot of our management. So we just wanted to kind of mention her. And as I said, we'll find out a little bit more about her later. We've actually got one of the clinicians that helped treat Grace in the crowd, don't we?
We do indeed.
Bit of a shout out. We've got Dan down here. Woo! He's the gentleman with the lovely moustache. He was one of the airway doctors that was on with me as well. So if you've got any questions, feel free to ask him too. All right, we're going to jump into some management after you.
Yeah, okay, so management-wise, this is one of those where the danger response type of thing does occur. So we're going to start with a plug for the pre-hospital setting. So pre-hospitally, it's all about access and extrication. So getting to the patient in a timely manner, and then trying to get the patient out of the submerged state. The key things we want to talk about in this are essentially the fact that, I guess you don't start CPR. That's probably the most obvious thing. Anytime you start CPR in the water, it becomes a waste of time. It's usually ineffective and it delays time to effective treatment. So the idea is extricate, get to a safe space, and then start your resuscitation there. There's a lot of talk about using horizontal extrication as well. So the idea is the water pressure essentially changes the fluid shifts around, and if you then verticalize, you can cause fluid shifts, circulatory collapse in there. So that's our danger and response. Off to airway. So airway-wise, we talk about clearing and protecting the airway, and that's like all cases. And remember that these patients are high risk of aspiration. So kind of the key terms that we wanted to use in here was make sure solid airways are high risk in here, so protect the airway for that. Anytime there's an altered level of consciousness, consider airway protection. And then if there's persistent hypoxia despite using high FiO2s and high flow oxygens in there, that's an indication as well for intubation.
Yeah, I think something here as well, and we're going to jump into breathing soon, but cuff tube is pretty important here. We'll mention shortly about PEEP, but definitely worthwhile if you've got a cuff tube, use a cuff tube. This was, I think as well, with Grace, this was particularly important, is the soiled airway was a real difficulty. Kids will eat, all day, and in this case, Grace had eaten blueberries. And so when the paramedics arrived on scene, they attempted to intubate, and they did intubate successfully, but when they handed over and reported to us, they'd mentioned that they saw blueberries in the mouth. And this became a problem later on when we were trying to ventilate, because we thought, is there a blueberry down in that lung? So yeah, definitely soiled airway can be really difficult, and often there's a report where they'll get a lot of red foam coming up, and this can cause just really soiled airways, real poor difficulty when you're trying to intubate. See those local cause. On to breathing.
So breathing, essentially the idea is breathing is probably the key tenet to all this. Hypoxia is one of your biggest complications related to drowning. So the first thing is, if they are in some degree of arrest, rescue breaths before you start CPR. Often 5 rescue breaths will be enough to get some kind of response. And we've got to give a big shout out to PEEP. So PEEP and high FiO2s. In Grace's case, she got almost 15 of PEEP, so almost 1 per kilo PEEP earlier on. Expect the fact that their pressures will be high. You just have to tolerate the pressure earlier on. I think the idea here is obviously you want to oxygenate, and also because essentially with the alveoli collapse, you want to try and recruit them back into the game. The other things that we found quite interesting with this case was obviously suction, and then using a gastric tube to decompress the stomach. Often that will also structurally relieve the ventilator while they're on the track.
Yeah, absolutely. And I think depending on who you ask as well, it can even be a pre-hospital consideration, particularly if resuscitative measures are difficult. Not something I think would commonly occur. I mean, this is coming from an ED nurse, but definitely if they haven't got one on arrival, we'd be looking to get one in pretty soon.
Circulation, yeah. So supportive cares is a large tenet of this of circulation. So fluids if they're hypovolemic. The big interesting side of this is probably the arrhythmias that happen with it. So if we're talking hypoxia, it's usually that bradycardia, the PEA, and systole. You can get tachyarrhythmias as well. I think my big take home from all this was that all these rhythms are probably related to the fact that they have drowned, and this is all in response to a hypoxic process in there. But we always say keep an open mind to other causes as to why someone's drowned as well.
Yeah, perfect. Disability.
Yeah,
right.
Disability. So in Grace's case, she scored herself a C-spine collar. This is something that we do have a little think about often. The literature suggests that there's probably a very low percentage of people who are submerged that do actually have C-spine injuries. So the question is, when do you consider it, when do you not? I think obviously this is probably going to be contextual. If you are worried, apply a C-spine collar. But the general idea is, if it's a child that's found in a pool, probably unlikely to have a C-spine injury. If you're a Bondi surfer, you've been dumped in the surf, then your chances are much higher. Otherwise, for disability-wise, it's a GCS assessment and then kind of progressive assessments to look at your neurological recovery and outcomes. And it's probably most important as a prognostic indicator. And then the last one's environmental. Environmental is actually really important in this case. And as we kind of know, most people who are submerged are hypothermic. I guess unless you've been submerged in a jacuzzi, you're probably going to be cold to some degree. And this is very different to what we'll talk about a little bit about being drowned in cold water. So this is the body being cold. The gold standard would be core temperatures, so rectal, esophageal probes. And then talking about rewarming. So simple stuff, get wet clothes off, dry the patient. You can try rewarming with warm blankets, and then the kind of central warming methods like humidified water and oxygen, warmed IV fluids, and then something we'll touch on a bit later, the use of ECMO to warm patients back up.
Yeah, does anyone work somewhere where you would expect to get water temperatures below 6 degrees? Yeah? Can I ask that?
I'm in here in New Zealand at the moment, but I used to work in the UK as well.
Yeah, awesome. Yeah. So I think if you are working in an environment where you do get really low water temperatures, and I did actually have a quick look, so the lake behind us is reaching about 5 degrees. So potentially if you work in Queenstown, some of your protocols might dictate changes in even just resuscitation time and prognosis, and this is why we'll talk about it more so when we get to prognosis. Because yeah, that kind of 6 degrees is the mark that if the water temp is less than 6 degrees, often the body kind of has this different response and allows for a prolonged resuscitative measure with still a likelihood of decent outcome. Yeah. But yeah, if you're working in Queenstown, be a consideration. I think if you do work somewhere that those water temps get low, have a look at your local protocol, it's definitely worthwhile. But I think for the majority of us, it's warm waters. So, every patient should get antibiotics. Agree? Disagree? Who says yes? Who says no? Yeah, cool. I didn't want to hang on yes there. Because ultimately, no. Patients should get antibiotics prophylactically if they're in contaminated water. Now, what's the definition for contaminated water? Pretty much, it's sewage. So if they're drowned in sewage, I think there's far greater concerns. But you would give antibiotics, ideally. or say maybe floodwaters, which is something that we may encounter a little bit more commonly. So, you know, good old Alfred almost gave us a little bit of that earlier in the year. So yeah, no is ultimately the answer. We shouldn't be giving prophylactic antibiotics to everyone. And I think this is an important discussion point when we think about where our disposition is and where we want to be with these kids. If you're having difficulty ventilating and we are stuck on A and B, the idea is you probably just want to be up in ICU or up in PICU. And this was definitely the case with Grace, is we just, as soon as she was in, we're having a bit of difficulty ventilating her. Our critical care consultant, who's actually also one of our ED consultants, his response was, I just want to be in PICU. And so we didn't delay, we didn't wait to try and give antibiotics, to do all these other measures, and we just went straight to PICU, where they could then do measures that we ultimately don't do in ED a lot, such as proning. They also jumped on their ventilator, which was just a bit better than the Hamilton that we were using. Because ultimately when we plugged it in, she was getting, it was just high alarming for pressures. And this is what you're going to encounter quite a lot, and you do start have to tolerating higher pressures. And so for questions like this, and the reason that this slide's in here is kind of what are the things we want to focus on, what are the things that we want to do in ED, versus what are those things that can just either wait or be discussion later on. All right. So, big decisions. Ultimately, this is prognosis. So, I'll quickly kick us off on this topic. So, there's a lot of things that are obviously going to weigh into your prognosis and weigh into your decision making around, do we continue resuscitative measures or do we not? But I want to focus on two, and they're the ones that are up on the slide. So that is submersion time and CPR. So submersion time, the 5-minute cutoff is kind of where we start to see a change in that prognosis. So if we've got a duration of submersion less than 5 minutes, the chance of survival sits above 90%. And this is a bit difficult because, I mean, it may not be witnessed. We may not know the submersion time. Whereas once we hit past that 5 minutes, it starts to drop drastically. So I think it works out, you've got some stats there in front of you.
Yeah, so it's usually, so within 5 minutes, about 10% mortality rate. And once you get beyond kind of the 5 minutes, you hit about 50, and then all the way down to over 25 minutes is almost 100% mortality. So you go from kind of 1 in 10 chance to flipping a coin to almost no chance. So that's why this is such an important factor there.
Yeah, absolutely. And I think one, yeah. Yeah.
Does that submersion time start when you take that last gulp?
Yeah. So
Yeah.
that's going to be hard
Good
to kind
question.
of figure out based on the story, right? So it's almost seen as the time that they're water from, but it would be essentially from the last gulp of water.
Yeah, and that probably brings me to the next point on that, is how often do we actually get a witnessed event? Ultimately, if it's a witnessed event, it's probably far more likely to result in a rescue, okay? Versus an unwitnessed event, you're going to get pulled from the water, and we don't know. So what do you do if you've got an unwitnessed event? You don't know submersion time, you can't prognosticate from that point of view. The likelihood, particularly in a paediatric population, I think most people would agree, you continue measures until you can either find out some more information, or there's other things, perhaps you reach ED and you can use some of those other prognostic factors at play. And this was the case, Grace was a particularly interesting case from this point of view because we didn't know her submersion time, she just got pulled from the water, but the family had CCTV, and so that was something that we found out actually later down the track and supported that prognostication when we were managing her. So she presented as an unwitnessed, but then later on it kind of became a witness case. And the other one, we had actually changed the slides a little bit this morning. So this one was just meant to be CPR, because it's kind of two things. Is how long did it take for them to start effective CPR? This one, if they get it within less than 10 minutes from getting pulled from the water, then they've got better chances of a good outcome. If it breaches over 10 minutes, which I think would be perhaps a situation where if we've got any paramedics in the room, you would rock up to scene, there's nothing going on, and you're the one that's starting resuscitative measures. I think, I mean, unless you're around the corner, your response time might sit outside of that 10 minutes, probably fair to say. So that might be a bit of a poor indicator and something you would hand over to the team when you arrive in ED. The other one is duration of CPR. So the time frame we look at for this is 25 minutes. they've got if they're ongoing CPR for greater than 25 minutes, their prognosis is relatively poor, or very, very poor really. And the other way that I would look at this is if they're getting CPR on arrival to ED. Again, I think scoop and run straight to ED, you're still probably sitting outside that 25-minute time frame of CPR. And so if the child's getting CPR on arrival to ED, prognosis is likely to be poor. Do you have anything else to add on that?
Yeah, so there's a little handy criteria score for this. So this is an all-asking score looking at kids who drowned and kind of their survivability. So it looks at things like age under the age of 3. It looks at their submersion time of 5 minutes as the cutoff, and then time to CPR, and then when they're still unconscious on arrival to ED, and then their pH at arrival as well, with the idea that if they're under 2 of those points, they're essentially a good chance of survival, and if they're greater than 3 or above, sorry, they've got a 5% survival chance.
Yeah. Now we have this slide in here as what and where, or where and when, sorry. With regard to, if you are arriving to scene and you've perhaps got that already immediate sort of know-how that this prognosis is going to be poor, where do you make this big decision? And I think ultimately this is more just a discussion point. I'm not going to stand up here and suggest that I know what the decision is. It varies every single time. But I think being aware that, on scene is a very uncontrolled environment, you might have a large crowd, you've got parents that are very, very distressed, is taking those things into consideration when you're making that decision. We did actually put a slide in here just before we jump onto the next one, which is a little video about ECMO. Did you want to mention anything too?
Yeah, so ECMO is one of those.
Who's in an ECMO centre? Yeah, cool. All right, cool. This might be a consideration for you.
Yeah, so ECMO is one of these fancy new things that we look at as a possible avenue for treatment in these situations. So the typical idea is it's for a hypothermic patient who's hypoxic, and you'd be using what's called a hope score to try and figure out their chance of survival. With, I like to say, a hope greater than 10 is a good chance. And it actually takes into account asphyxia. So in this case, submersion, we equate to asphyxia by lack of oxygen. So that's quite a useful way of determining whether someone would be then candidate for ECMO as well. But like Ollie was saying, these are quite sensitive situations. I think in a paediatric drowning, in most cases, people will commit CPR regardless. Kind of what Dr. Mark was saying before, a lot of this is like getting families involved and trying to communicate what's going on and showing them that you are making an effort in there as well. And that's quite an important side of the process.
Absolutely. Good segue into this little video. So it's about, got a small video, and this is a little bit about Grace's story. So turn your eyes to the screen. And then if there's any time left, hope to get some questions afterwards.
Hello.
So what's your name?
What's your name?
Gracie.
Gracie. How old are you? 3.
How many is that? Can you show us?
Show Oliver how many that is. Show us with your fingers.
Good job.
So they're big. She was in the pool area and she had reached for something, and Grace is only a little girl. She's quite a small 3-year-old, and she had reached into the pool behind this large couch lilo, like a very heavy duty. You can jump on fully clothed and it does not sink at all, like go under.
Yeah.
And she was reaching for something and had fallen in and slipped straight under that against the pool, and just nobody could see her. So overwhelming with what felt like 50 people in the lounge. And I know it wasn't that many, but it felt like I couldn't see her. There were so many people. And I'm standing in the room thinking, what's happening? Like, what are they doing? What's happened? Like, have we going back a step? We can see everyone going in and out of that room when Grace came back, and they were like, we'll call you when it's time to come, but at the moment just stay here. And I just remember that I said to Joe, I'm like, why is this taking so long? It just felt like an eternity. And it was a long time. It wasn't just like 10 minutes, it felt like an hour. It was a long time.
That time,
No.
wasn't it?
Those real perceptions. I think it was, like maybe 2 hours. It became like 9 o'clock and they sort of said to us, we're struggling to get her oxygen above 60%. Moved into the PICU, into the Paediatric ICU, and she was obviously on life support there. And I remember on day 2 or day 3, they said to us, one of the head doctors of PICU said to us that there's a high chance that Grace won't make it.
Yeah, I remember that.
And that's when we found out about the 6 minutes, and they sort of just said to us, in these cases, it's not looking good. It's not a high chance that she will survive. In fact, we have to let you know that there's a high chance at this point that she's not going to survive.
Yeah.
And they said if she survives at this point, she will have severe brain damage. I felt like a lot of guilt for Noah, like I really struggled with him because he is such a good boy and he like adores Grace.
You just quite didn't understand what was going on.
I didn't want her to go to hospital, so I wanted her to play with me every time. That's why I love her.
Day 5, somehow, I can't read what they know and they understand, but they brought us into a room and said, look, like, things are looking good and we now think she will survive.
Where's Mummy? Where's Mummy? Where's Daddy?
Say thanks, Grandmama.
Not again, yeehaw!
Yeah, head up, man.
Sure. All right, that is us. I've lost the clicker. That's their presentation. Thank you so much for having us, and huge round of applause to these guys too, for organising this. We love being here. I think we've run out of time for questions, but we'll be hanging around, so if anyone's got any questions for us, then please feel free to come approach us. Awesome.
Thank you, Oliver and James. So let's take a moment, catch your breath. If that was challenging to watch, please reach out to your support networks or chat to one of us. We're here for you guys. So take a couple of minutes and then we'll get going with our last presentation. Thanks so much for just making that a quick break. And just before I hand over to Caitlin, it's time for our photo competition. So thank you everyone for sending photos through. There were a few that came through very early this morning that we didn't have a chance to put on for today, so they will go on tomorrow. Please keep the photos coming. The idea behind the Wednesday morning session is not just to get you all up early, whilst you're still a bit jet lagged and whatnot, but it's really just so we can get the presentations done first thing and you guys can get out and explore and enjoy the day and into the evening. So want to hopefully see heaps of photos coming in. We really want to see what you're all up to. Peking ducks playing tonight if anyone's heading out to the snow, so that's something to get excited about. So if anyone gets any video of that, we'll definitely be showing that tomorrow. So hopefully you know the rules. Loudest cheers get the prize. We've allowed about 2 or 3 prizes to give away. So let's get started with our first one. What do you reckon? It's always hard going first when you're warming up. Oh, that's pretty nice. Very artistic there, I like that. Oh, some snow angels. Excellent. Excellent. chairlift photo, nice. All right, I reckon we'll have the snow angels and the ski goggles. So well done, guys. Please see Dylan, myself, or Ben at the end to get your t-shirts. I'll now pass straight to you, Caitlin. So let's give a nice warm round of applause for Caitlin.
Can you hear me at the back? Amazing, I'm Caitlin. I work as an ONG, Pietro, or in other states it's called like an unaccredited registrar in Toowoomba in Queensland. And today I'm going to talk to you about ONG and the ED because I receive thousands and thousands of phone calls. So if you have any questions throughout the presentation, please just call out and we'll go through them. So obstetric emergencies in ED or coming to the ED, I talked to some of my friends who are paramedics, I talked to my ED nursing colleagues, and very conveniently my boyfriend is the ED registrar, and I said, what freaks you out about ONG and the ED? And they all said the same thing, maternal collapse or women coming in bleeding or increasingly home birth, which is a whole another topic in itself, which might need a whole other presentation, but I said the most common thing they said was mums that have collapsed and what to do and where to go from there. So of course there's heaps and heaps of things that can cause maternal collapse, and I'm going to go over the ones that really pertain to me as the ONG registrar who gets called to them, but of course you guys would be way better at managing like anaphylaxis or aspiration, asthma, all of that kind of stuff, but the things that I worry about are the cervical shocks, the ectopic pregnancies, preeclampsia, very rarely amniotic fluid embolism, PE kind of has a lot of crossover, PPH of course, and sepsis. So maternal collapse encompasses from when you get pregnant until 6 weeks postpartum. So I think lots of people think, oh, maternal collapse is a visibly pregnant person, but that's not necessarily true. It can be someone who's got, like I said, a miscarriage or an ectopic pregnancy as well. So maternal collapse, I know all the presentations so far I've included this, but I just want to nail it one more time. Having that really good algorithm, the calling for help, airway breathing, circulation, disability exposure is what I know you're all really fabulous at doing already. Some small considerations for pregnant people or people who are visibly pregnant, so probably over 20 weeks, is having that left lateral tilt and maybe the displacement of where you're going to do your CPR, because a gravid abdomen is going to push up the diaphragm and cause a bit of the heart to shift, so where your CPR placement is important to think about. I think my side says right, but it's actually the left is where the heart's moving toward. And defib as well, that's totally safe to do in pregnancy. I've had some calls previously about that. Is it safe to do? Yes, because if she's not got a pulse, the baby's probably going to end up without one as well. Awesome, and then of course we always talk about like peripartum or post-mortem cesarean section. So if you're doing CPR and there's about a 5-minute period where there's no return to circulation, that's going to be your emergency measure, is to do perimortem Caesar. I'm not really going to talk about that today in this presentation because that's quite rare, and I think unless you're doing perhaps like rural generalism out in the bush, where there's no cover to come, probably have an ONG register will come down very quickly to help you, but of course if you've got any questions you can go through that as well. Okay, cool, so cervical shock. So cervical shock is a vagal nerve response from descension of the cervix, most likely because of miscarriage or retained products coming through the cervix, and it's really unusual form of shock because of course it has a bradycardia and a hypotension, whereas most sort of shocks, as you will all be aware, have a tachycardia and a hypotension. Like I said, it can be from incomplete miscarriage, retained products, or expulsion of like an IUD, like a marina. Taking history is obviously important, but if they're pale or dizzy or collapsing, they might have some vaginal bleeding or they might have very minimal bleeding. And if you do a speculum, you'll see that the cervix is open. So this is also a common question, and a question that I got asked on Monday night as well. When should we do a speculum exam? I take about a dozen phone calls a day. Oh, do you think this person needs a speculum? I would be the OG reg if I didn't say yes, they need a speculum. It's a really, really common exam. It's a really routine exam. I think it gets a bit confusing. OG, you might come and examine them anyway, but I think that doing the speculum, doing more speculums, just means you'll be better at doing them. You'll know what normal looks like, and then you'll know how to say to me, well, it looks really unusual what I've seen on spec. Some tips I have for speculum exams is always have a chaperone. ED is a terrible place for speculum or intimate exam in general, so I always spin the bed around or get the patient to spin around the bed so their legs are facing the wall, not the curtain, which is a nice thing to do, and then no one gets a surprise if they accidentally walk in on speculum exam. The EDI worker has a torch on the speculum, which is really helpful, but if you have a speculum without a torch, ask the patient to use their phone, never ever use your phone. I know that sounds really simple, but it just happens all the time. There's some tests that I do in ONG that can't use lubrication, but there's almost nothing that you do in ED that can't use lube, so use lots of it. I always tell my interns and residents when I'm teaching them things, set up for success, so have everything you might need. So if you're treating someone for cervical shock, have everything you need ready to go, even if you don't end up using it. So have your sponge forceps, the big jumbo Q-tips, some swabs on a stick and things like that. So sometimes you can do a speculum, you can just see the cervix, you can use the jumbo tip to push it into view, and then you can see if it's open or not to then remove products if you need to, or wipe out some blood if it's there as well. Some speculums chew the bottom bill. There's a bill that's longer on it. That's the bill that's going to go into the posterior fornix, and often that means the handles are facing down on the bed, and people find it hard to really open. So putting a rolled up towel under the patient's sort of sacrum as well can really help, and also moving the bed away from the wall so they can really relax their legs out into that butterfly or frog leg position, whatever you want to call it. It makes it much more helpful too. And that's it. And I also get people that angle really posteriorly down and fan back up. I think it's the easiest way to do it, but I'm sure you're doing a fabulous job. So whatever you do, keep doing it. These are some pictures of cervix of what you might see, or hopefully see if you get your speculum in the right position. So the first picture, does anyone know what you're seeing in the first picture? A marina, yes, amazing. Yep, that's an amazing marina in what's probably an ulnar cervix as well. Picture number 2. Yeah, purulent discharge, horrible. Probably with someone with chlamydia, and you can see the cervix as well, looks very, very red and angry. Number 3. It could be CIN, it's a bit hard to know 100% for sure, but it's probably an ectropion, is the other differential for that picture too. So commonly I get called like, oh, the cervix looks really red, and if it looks somewhat like that, it's possibly an ectropion, which is just from either being pregnant or being on the pill and things like that. So that's really normal change to the cells of the cervix. Of course, if you're in GP, then you see that probably worth doing a CST as well, so they might be coming in with bleeding and things like that too. And the last one, any guesses? Yeah, retained products, yeah. So if you saw that, I'd recommend removing it because patients will be bleeding, or in this situation that we're talking about, cervical shock. So being able to grab onto it with the sponge forceps, it's really friable tissue though, so sometimes it will fall apart. I sometimes get the patient to give me a little cough or bear down, and that can help move it through. There's another amazing medication that you guys all have access to in the ED, it's called misoprostol. I love misoprostol, we use it for almost everything in ONG, and that can just help the uterus to contract down, help the cervix to open, to help the miscarriage of the products move through as well. So it would be 800 micrograms buccally, which is, yeah, that would be useful to use. So management, this is, yeah. Yeah, so it works probably within 30 minutes to an hour. So routinely we give about 400 micrograms prior to like a DNC, an hour before we do a DNC. So we recommend doubling that for this situation, and it does have a pretty quick onset. We use it in PPH as well for the same reasons. It's not like I think you could use it pre-hospitally as well. As in, do you mean when you've had a birth? Yeah. No, we use it like in conjunction with each other. Yeah. The question was, can you use oxytocin like after a birth? And misoprostol, 100%. It's all part of the PPH algorithm. So yeah, that's good. So yeah, you've got to do all the things. So call for help. Be set up properly in the room. Speculum exam. Make sure you have IV actives and fluids. And you should observe like a rapid resolution of the cervical shock. So they should feel so much better. Their hypertension's improving. Their bradycardia is improving. I would still probably recommend having a pelvic ultrasound because sometimes it's hard to know if the uterus is completely evacuated or not. Maybe this was retained products, maybe it was a really large clot that was sitting there. So having a pelvic ultrasound is really helpful as well. But yeah, that's one of the very good reasons a speculum exam is helpful. Next topic, ectopic pregnancy. So again, this is a really, really common occurrence. It can be as simple as, it's an incidental finding on an early dating scan, or it can be severe life-threatening bleeding. The largest ectopic rupture I've seen is about 6 litres. but other times we do them there's no bleeding as well, so it can be very variable. And I think this is something that's taught to us from like day one of medical school, hopefully day one of nursing and midwifery and paramedics as well. If someone is of reproductive age, has abdominal pain, bleeding, and can't remember when their last period is, or has a positive pregnancy test, that's going to be an ectopic until proven absolutely otherwise. So it's about 1 to 2% of all pregnancies. More than 90% are occurring in the tubes, but can occur in other strange places as well, like the cervix or in the abdomen. They are responsible for 80% of maternal deaths in the first trimester, so that's why I really care about them. They've got about an 18% risk of rupture across the board, so that's also why we care about them. Risk factors for them: smoking, advanced maternal age, previous sterilisation, previous ectopic, sort of the most common things, or having like a tubal dysfunction from something like pelvic inflammatory disease previously. So again, you know that abdominal pain, bleeding, and positive HCG, they might have that classic shoulder tip pain as well from blood being up near the diaphragm, irritating that peritoneum up there. Syncope, so if someone said, oh, you know, I've had a case before, I've been called like, oh, she's stable, there's no rupture, but she did have a faint earlier today, but she's okay now, that's like a red flag to me to say, no, we need to do something about this, because they shouldn't necessarily have a faint with it. They might have some adnexal tenderness or some cervical motion tenderness, but of course that can have crossover with pelvic inflammatory disease as well. In Australia, we use a discrimination zone for HCG, which is the pregnancy hormone, of about 15,000. 1500, and if you can't see an intrauterine pregnancy at 1500, that should again raise your suspicion for, is this going to be an ectopic pregnancy in some way unusual, because an intrauterine pregnancy should be visible at 1500. Amazing, so this little page is from the Queensland Health Guidelines. Queensland Health has excellent clinical guidelines, I think. Maybe I'm biased because I work for Queensland Health, but not that I'm here representing them, they want that to be very clear. But the main thing I want probably you to take away is if this can be medically or surgically managed, because lots of ectopic pregnancies can go through our early pregnancy clinics. If they're stable, if they don't have any bleeding, depending on what the level of the HCG is or the size of the pregnancy, if there's a fetal heart within the ectopic pregnancy, because you know that's important to know for us. But if there's any sign of hemodynamic instability, excessive pain, they're all reasons that we should be taking them to theatre. I did have a slide with a picture of an ectopic, but it must have deleted it out. But anyway, essentially sometimes we go in, there's just a belly full of blood and a really large injected tube that we likely will remove. Cool, so preeclampsia. So you probably get hundreds of calls being paramedics saying, oh, she's a pregnant woman, maybe she's got a blood pressure that's up, she's got a terrible headache, needs to come in. Of course, always bring them in. Just want to make a little note that our hypertension is different to lots of other ED things. Sometimes I get a call very casually like, oh yeah, she's well, her blood pressure's 160, but she's doing amazing. I'm like, oh, that's very high. So our cutoff is 140 on 90 for pregnant women. Anything over 140 and on 90 is something that we want to see. We might not need to medicate them, but we definitely want to investigate them for preeclampsia. Of course, with preeclampsia, it's not just blood pressure. There's usually another end organ dysfunction, so whether that's liver dysfunction, renal dysfunction, protein in the urine, visual disturbance, headache, hyperreflexia or clonus, they're all things that I'm going to be looking for when I examine them for preeclampsia. And of course, it's called preeclampsia because it can lead on to eclampsia, which is generalized seizure in a pregnant woman, which is normally self-terminates reasonably quickly, but like anything, you follow your normal seizure algorithm, and you know, anyone can get pregnant really, so they can have epilepsy as well, so there's lots of differentials. Why it's important for maternal collapse, because of course you can end up with having a seizure. If the blood pressure is really raging, you can have like a hemorrhagic stroke. It can lead to cardiovascular instability. It can lead to something called HELP syndrome, which is hemolysis, elevated liver function, low platelets, which can then flow into becoming DIC. And of course, you know, with preeclampsia, there's lots of edema and third spacing of fluids, so it can also cause pulmonary edema. So that's why we care about it. And then again, I've just put those clinical features that I'm looking for to make a diagnosis on the side there. So again, these guidelines are from Queensland Health. They're really easy to follow. Queensland Health seems to love flow charts, and they're really just good points to move through. Again, if we see someone or we bring them in from home, you know, you're going to call for help, make sure their airway is fine, that left lateral tilt again, having IV access. We then, when we see them, depending on how stable or unstable they are, we make a decision about whether we're giving them antihypertensives and whether we need to protect them neurologically. And the way we do do that is with magnesium sulfate. So we give 4 grams of magnesium sulfate over 5 to 10 minutes, and then 1 gram per hour for the next 24 hours. But the ultimate thing we need to do with preeclampsia is deliver the baby, to deliver the placenta, because it's thought to be a disease from the placenta. And the other key thing is we don't want to bomb their blood pressure too low, because of course that can lead to hypoperfusion of the placenta as well, which is also bad for baby. So it's a really fine balancing act. But I guess the key thing I want you to take away is that 140 on 90 in a pregnant woman, always give OG a heads up. Yeah. Well, I think so. When you're normally pregnant, people have like a lower blood pressure anyway. I think anyone who's getting a blood pressure in the 80s is a bit alarming. I'd normally tolerate that, like young, fit, and healthy. The question was hypotension in pregnancy. So young, fit, healthy women probably have a blood pressure of like 90 to 100 systolic and maybe higher 50s to 70s diastolic. So I'm pretty tolerant of that. But of course, if they're symptomatic with that blood pressure, if they're feeling dizzy, if they're feeling unwell, then that's not normal for them. We should do something about it. Yeah. Cool. Amniotic fluid embolism. So the reason I popped this one in here, because even though it's really, really rare, it can be, of course, catastrophic, carrying about a 20 to 40% mortality rate for mums. It's called embolism, and when I was a medical student, I thought, oh, it must just be the fluid like going into the lungs like a PE. It's not really. It's more like a inflammatory response, kind of like an anaphylaxis response in some ways. It's not like I said, it's not really a true embolism, but it can occur during labour, delivery, or even postpartum as well. Classically, they have sudden onset hypoxia and shortness of breath. They'll be hypotensive and they'll be coagulopathic. So it's the kind of person that if they're having it during a cesarean section, every stitch I'm putting in, it's bleeding from every stitch, or they've birthed, and no matter what you're doing, when you bring in the hospital, the bleeding just keeps coming, and they're becoming short of breath and all the rest as well. Other things that can occur is things like seizures, cardiac arrest, and the uterus is becoming really lax as well. So it's amniotic fluid going into maternal circulation and triggering this inflammatory cascade, and then moving on, leading to vasoconstriction, heart failure, and then DIC as well. So the management of this, again, I'm sure you're getting the point of my talk, just always calling for help is so important. So calling for help, using your airway and breathing techniques. We love fluids and OG, but of course with the asterisks about preeclampsia and fluid restriction, but we can talk about that later. And then normally I'm needing to use my ICU colleagues for this kind of stuff too, because the vasopressor support is not something that we do on birth suite, it's something that we need help with as well. So like with all of these things, it's a really team effort to help manage these patients sometimes. And of course, if there's going to be a high rate of maternal morbidity and mortality, there's also flow-on effects for babies as well, so that's why we care about it. Cool, so PE, again, this is something that you guys in ED are like amazing at managing, you're really fabulous at this kind of stuff, but there's a lot of crossover with us, and we get a lot of questions about it, particularly because of radiation in pregnancy. So of course, as you know, PE is a thrombus that's probably come from the leg moving into the lung, and it's a leading cause of maternal morbidity and mortality in developed countries. Pregnancy is a hypercoagulable state anyway, so you're more at risk of getting clots and things like that. We score all our women, at least in Queensland, I'm sure you're doing it in other states as well, for their risk factors with bleeding. If they have sort of 3 points on that risk factor scale, they'll likely be on clexane anyway in pregnancy, but that doesn't mean that they won't end up with a PE. So normally when I'm in maternity assessment, which is sort of like ED for pregnant ladies, we're getting people brought in with chest pain, with shortness of breath, which I'm getting better at dealing with, but also that's like really ED's, special skill, dealing with chest pain, dealing with shortness of breath. You guys are legends for that. But they can also come in with syncope, hypoxia, that terrible pleuritic pain. Normally we do an ECG and an ABG, but if I'm really worried, I'm going to do a CTPA. I get a lot of questions like, oh, hey Caitlin, we've got a pregnant lady down here, we've done a D-dimer. Thanks, but essentially probably save that one or not use it at all. But in pregnancy, it's probably going to be elevated anyway, so it doesn't really change your decision making. If you're worried that someone has a PE, you should do a CTPA. Let's talk about VQ scans as well. I guess they're not as readily accessible. But a CTPA is really safe. The thing you're worrying about is radiation to the baby. It's about 50 micrograms to cause sort of teratogenic effect to the baby, and the CT scan is far, far less than that. So please, obviously you're not going to do 100 CTPAs during the woman's pregnancy, but please use one if you're worried that she doesn't got her embolus. Cool. So again, management, we're calling for help, doing CPR if there's an arrest. This is a situation where if there is arrest, we're probably looking at a perimortem Caesar. And if it's not, if it's a suspected PE or a confirmed PE that hasn't caused an arrest, we're going to do things like put them on prophylactic, therapeutic clexane rather than prophylactic, and start making a plan around their delivery so we can do that in a safe way as well. I made this little table about why they're different, essentially like they're totally different things, but the word of embolism I think confuses people sometimes, so I'll just make this little summary about all of it, which I don't know, selfishly is probably more helpful for my exams than for any of you, but cleared it up in my mind. Cool, so PPH. The definition is slightly changing at the moment, but currently as it stands, if it's a vaginal birth and there's more than 500 ml of blood loss, or a cesarean more than a litre, or any point where there's been blood loss that has caused, you know, hypotension or hemodynamic instability to mum. Risk factors, so if there's a twin birth, if there's a really long birth or a really quick birth, so ultimately we're saying we want a birth that's timed perfectly, which is almost impossible. You know, induction of labour increases your risk. People who have had polyhydramnios, so really, really high amounts of fluid around baby in their pregnancy because the uterus is really distended and has to contract down so much more. If they've had a previous PPH or if I've done a cesarean or a forceps on them, that's going to increase that risk of this as well. Does anyone know the 4 causes of PPH? Amazing. So tone, tissue, trauma, thrombin. So tone is responsible for 60% of PPHs. So that's, you know, if the uterus is feeling really boggy, I sort of should feel like if you've ever felt a softball, like really hard, like and firm under the umbilicus. If someone's full term, their uterus is going to be up near the edge of your sternum. It should be down below the umbilicus after that big birth. It should feel nice and firm. If it doesn't feel quite like that, and you give it a rub and here's blood clots are coming out, they're probably not contracted well enough just yet. Tissue, so we're talking about a placenta that's still in situ, or perhaps if they've had membranes, so that's why we're always, especially on first week, like let's look at the placenta, or you know, you guys having a look at the placenta is really, really helpful if you bring them in from a home birth or something like that, or even being able to bring it with you is a helpful thing to do. Trauma, so when I'm talking about trauma, I'm talking about vaginal tearing, which is really common. 85% of women have some kind of tear from childbirth, and that can obviously bleed, so it's really common as well. And then thrombin, that's sort of your funny coagulopathies, or more common things like preeclampsia that we can use other medications for, but that's sort of getting down the list as well. Again, fabulous guidelines that are really easy to follow. So calling for help, normal ABCs, assessing for blood loss. I don't know about you guys, but we're actually really terrible at assessing for blood loss and estimating it. I'm probably someone who overestimates it, so I'd rather be ahead of my PPH than 2 litres behind. So using things that you can, like weighing it as well, is really helpful. And we routinely weigh our blood loss on birth suite to make sure that we're being really accurate about it. Because sometimes, you know, we think, oh, maybe that was a litre, check that blood count the next day, and they've gone from 130 to 60, you're like, oh, definitely more than a litre. But that's okay, these things happen, we just keep getting better as we try. Doing frontal massage, so that's really firm. I watch a lot of really fabulous keen midwifery students have a go, but that's really, really gentle. It's a situation where you're not trying to be gentle, you're trying to stop the bleeding, so you do have to do a really firm, really hard rub, and rubbing down to try and get the uterus to contract down as well. The main things that we use for uterotonics, so things like oxytocin, really amazing. We can use ergometrin with a small asterisk that in preeclampsia we try not to use it because it can bump up people's blood pressures and it gets a bit confusing. Carboprost, misoprostol, all of those things come down the list of things we can use to help stop bleeding, put in a catheter. And then there's more serious things that if you're bringing them in from home and saying, oh, we think they've lost about 4 litres, we're going to take them straight to theatre and try and stop the bleeding with things like a Bacary balloon or maybe a V-Lynch suture, or absolute worst case scenario would be hysterectomy, which is about 1 in 50 to 100,000. Amazing, and maternal sepsis. So this is really, really important. I think it's, maybe we don't take it as seriously as we should because it is something that is a leading cause of morbidity and mortality worldwide, so talking about developed and developing countries as well. We always talk about how well young pregnant women, they compensate so well. It's not till the absolute last minute when they've lost 2 litres of blood in their abdomen that they're starting to show signs of shock or hemodynamic instability. And maternal sepsis is one of those things as well that, they might not show signs quickly, but when they do, they'll deteriorate really, really fast. So it's something that we need to try and have on the back of our mind, early recognition, so we can start treating it really quickly. And it can occur from any stage of pregnancy again. So I've seen septic miscarriages, I've seen people coming in septic post-abortion, postpartum in that 6-week period, or even during their labour, they can develop an infection as well. So most commonly it's a genital tract infection, so things like endometritis or choroamnionitis, or retained products, but it can be from other sources as well. So respiratory sources, urinary tract infection, mastitis, or even a wound like from a perineal repair or that caesarean scar as well. Risk factors, of course, having a long labour or a long rupture of your membranes as well. That's why we love giving some Ben-Pen when it's been 16 to 18 hours of labour. Instrumental birth, seizures, anyone who's immunosuppressed or has diabetes, of course, they're always at more risk for this kind of stuff, or any kind of invasive procedures. So if I've had to go in and do a manual removal of that placenta, they're going to have an increased risk of having that kind of bleeding. I don't need to tell you guys what to look out for sepsis. It's the same, it's just that she's pregnant or postpartum, but it's the same things that you're going to be looking for that you look for in your non-pregnant patients as well. Cool, so, and the same deal, just going to call for help, put some cannulas in, and starting broad spectrum antibiotics. So we typically use Gen-Amp and Metro. I'm sure it's probably true in the other states as well, but we've been using a lot of tobramycin at the moment because there's not been readily available gentamicin too, and it's been having the same positive effect and warding off sepsis for our patients. So something to always consider. Amazing, so that's pretty much me. I thought third talk of the day, it's not as fun as the last one, so don't want to take too much of your time. But yeah, calling early, having an obstetric focus, just thinking about those little things that you can do to help improve your ability to provide a resource to patients. We think about mum and then baby. Of course, it's like a split second between the two, but if you need to be able to keep mum there if you're wanting to keep the baby, and ultimately we need to try our best for her. And having a good team. So I really appreciate all of you bringing me these patients, calling me for referrals, because I can't do it without all of you. So thank you so much.
Thank you, Caitlin. Does anyone have a question?
Yeah.
Any contraindications to Prehospital in the like
Not that I can think of. It's pretty safe medication. Of course, if they've had like a previous adverse response to it, they might be a bit dubious about taking it. So Prehospital can cause like nausea, vomiting. It can cause some diarrhea as well, loose stools, and it can cause a low-grade fever as well. But I can't really think of any contraindications yet. Yeah.
If you're blood pressure, if you have something that it's like they're 125 or 95, are you concerned because of diastole?
Yeah. So it's not like it needs to be both numbers. It's one or the other or both. So yeah, if they had a diastolic of 95, I'd still want to see them and work them up for preeclampsia, definitely.
Yeah. Pearls for like, particularly the like that no prenatal care type patient.
I love what are they called? Radical birth experience is what they've been calling. So the question was, is there advice for women who have had no antenatal care? I think it's really tricky, and those people, there's probably lots of reasons they don't want to seek help. One of them is probably because they're a bit scared of what might happen when they come to the hospital. Like what Dr. Mark was saying earlier, like that communication is really key, trying to get them to come in. And they often come in and we have no idea what's going on with them as well. So we just do all their normal bloods and try and talk through about what's going on. Maybe like working on having really good abdominal exam techniques to see if the baby's cephalic can be helpful, because that value people who you might end up having a breech birth, which if you're coming to the simulation, which we're always happy to have more people if more people want to come, we'll talk about how to manage that too. My boss Simon and I have been talking a lot about like scoop and run versus stay and play. I think a lot of these are probably scoop and run situations, unless, of course, we'll talk about with the birth things, but unless you can see a fetal part coming out, that's something that you're probably going to stay for. Otherwise, you're just going to try and get them in as quickly as you can. Yeah.
In terms of maternal sepsis, are you skipping your closest hospital to go to obstetrics at Paediatric hospital, or is it locally able to manage that?
Yeah, so that's a good question. I think, you know, we've got that golden 60 minutes, all hospitals have access to antibiotics, and I think that it would be okay to sort of turn up and be like, oh, like this woman is septic, we need to start some antibiotics, and then have an inter-hospital transfer. But I am not the director of medical services at any point yet, so I think that the hospital might not be very happy about that, but I think at the end of the day, if you've got someone who's critically unwell and unstable, like the closest hospital is where you're going to need help, and they, like a pregnant woman, just because she's pregnant doesn't mean she doesn't have the same antibiotic requirement or the same sepsis or requirement, and in fact, as I've just told you, like her morbidity and mortality risk is really, really high, so I don't think you're doing the wrong thing by going to the closest hospital, especially in peak hour traffic, where it might be 60 minutes to the next one.
From a drug choice option, oxytocin versus symptomatin for the combo, which would you use in which reason and for what?
That's a good question. So it's about symptometrin versus oxytocin. So symptometrin is oxytocin and ergometrin combined. I previously worked in Victoria, and the hospital I worked in, every woman, no matter what, got symptometrin for that active third stage. I work in Queensland now, and in Queensland everyone gets oxytocin unless they have significant risk factors. So if they have a risk factor for a PPH, often, and I'm the birth rate reg, I normally say to the midwives, oh, can we have symptometrin in that room? And normally that's just what we do. I think there's probably some really smart journal article answer for you, but I think it's risk factor dependent, and if, for my personal practice, if they do have risk factors and they don't have preeclampsia or gestational hypertension, I'll use symptometrin for them. Yeah.
Sorry, let's do this. For the contraindications say that had oxytocin versus oxytocin and measured in undiagnosed kids.
Oh yeah.
Did you investigate a case where information was given after birth, the first one was wild birth?
Yeah.
The information was given and it was the number
yeah. Yeah. Yeah, so that's probably something to think about, especially with the rise of home birth and particularly free birth, which for those of you who don't know home birth, there's normally like a medical person in attendance, probably a midwife, whereas free birth there's no medically trained person present. That's like the key difference between them. And I find that the free birth people are a bit more, they don't want kind of any help, and they really don't want to come to the hospital, and they're sort of like, oh, this is fine. Like I had 4-litre PPH last time and I'm still alive, and you're like, oh, you feel so lucky. But yeah, I think that's a really hard situation. Like twins are sometimes hard to pout when there's lots of fluid and there's lots of limbs and you're not used to it. So I love scanning people for a multitude of reasons, but that's sometimes when ultrasound's helpful. I don't know. I love ultrasound's really good, really easy, and hopefully you get one in your pocket soon. You can do that too. Yeah.
Pregnant women in acute pain, are there any modifications to the pain later that you would do in particular?
Yeah, so that question is about pain in pregnant women. Not like, do you mean like 0 to 10 or that kind of thing, or?
Yeah, and I guess contraindications and other things that you'll be considering for things passing through the ciliary and whatnot.
Yeah. That's a great question. So. Of course, we don't use any NSAIDs in pregnancy. We don't use ibuprofen, but paracetamol is very safe. Things like codeine and opioids are really safe in pregnancy as well. But of course, we don't really overuse all of that kind of stuff. We use a lot of heat packs, and a lot of recommend to hop in a hot shower and things like that too. Morphine does cross the placenta, so often if someone's in labour or imminently about to birth, we try and steer them away from having morphine because the baby can be affected from that. Epidural, amazing, doesn't cross the placenta, baby's really happy. General anaesthetic, of course, does cross the placenta as well. I think it's very dependent though, and I think what I try and counsel a lot of patients about, and I think what a lot of these talks are focusing on is the communication style, and I tell patients, pregnancy is uncomfortable and some pain is normal. Of course, sharp pain or sudden onset pain pain that mimics contractions when you're 32 weeks, that's not normal, but there are some, like round ligament pain, horrible and uncomfortable and doesn't really get better until the baby's out. That stretching pain or getting kicked in the ribs every day, that's not going to really improve. So we try and use other things like a belly band, or making sure that when they're getting out of bed, they're not just sort of sitting up, they roll to the side and get up, pushing up from the side to protect their abdominal muscles. So I think those things are important, but equally it's also important to make sure your patient's comfortable. Cool.
All right, let's hear it one more time for Caitlin. Thank you, Caitlin. And for those lucky enough to be going to the workshop, Caitlin and Simon will be in the little red room and we'll be starting quite soon after, probably about 10 minutes or so, just so we can set up. The journey continues tomorrow. We're moving on to all adults. So we're going to be talking about heart failure, a bit of trauma in there, a bit of a case study. So get excited for that. But before then, go out, enjoy the day, and we'll see you all back here tomorrow. Cheers.
Do you want me to turn this off now?